they delivered in such a manner that the team was really appreciated with the kind of infrastructure the department has built over the time and their expertise in all these fields. I also appreciate that the incubation center, which has been put in place by Department of Zoology, is also a unique one. And even the district administration, they appreciated the zoology department by granting them a good project in sericulture under the DPDC scheme. So in short, they are doing really wonderful. And let's take the today's lecture series theme, the 21st century zoology teaching, which is a very apt theme they have taken. And as you know that each century has been coined by scientific and technological progress. For instance, the 19th century was the century of age of engineering, while the 20th century, it was the age of chemistry and physics. And if you see the 21st century, even if you look at the themes of each year in the 21st century, you will find that the 21st century is the age of biology. And therefore, life sciences, they play a very critical and very important, very significant key role in tackling the global challenges. And to this end, zoology is a very, very important field, and dissemination of knowledge in this particular field is very, very important. And I'm sure that this particular lecture series will be the right kind of platform for brainstorming in the latest in this particular field of zoology. So I won't take much of your time because so many stalwarts are there, and they will be delivering this particular lecture series. My best wishes to all of you on this particular occasion, because in science, what's important is the communication is very important, and we need to communicate proactively. And as I can see, and Professor Deshmukh was mentioning that without any hesitance, the speakers, they agreed to deliver the talk. So they are really good communicator, and we need to speak a language everybody understands. And I'm sure that the language of science and the language of zoology will be properly picked up by the young community who are the audience of this particular lecture series. And my best wishes to all of you. And with this, I conclude my speech. Thank you very much once again for giving me this opportunity. Thank you, one and all.
Thank
Over
you.
to you, Dr. Bilavi, sir. Yeah.
Yes. Thank you very much, Professor Kamath, sir, Dean, Science and Technology of our department. Very nicely, he has synchronized the electronics with the zoology. Earlier, we used to have the vertical growth in our respective subject. For example, one is zoologist, another one is botanist, electronics, and computers, and all these things. But now the time has come to move towards the horizontal growth. And sir, you rightly pointed out in the lecture series on the zoology in the 21st century, in the capacity of the presidential address, that yes, zoology playing a great role in the computers and electronics too. Thank you very much for your beautiful presidential address, sir. Now, may I call upon Dr. A.D. Gopne, sir, to express vote of thanks.
Thank you, sir. Very good morning and a warm welcome to all the participants for their presence for this week-long lecture series, and as well as registering for this lecture series and attending this inaugural program. It is my great privilege to have been asked for proposing vote of thanks on this occasion. I, on behalf of this department, offer heartily thankful to all of you. I extend my vote of thanks towards our administrative authorities, Honorable Vice Chancellor Professor D.T. Sirke sir, Honorable Pro Vice Chancellor Professor P.S. Patil sir, and Registrar Dr. V.N. Shinde sir for their continuous support to happen this program. I would like to thank to our Honorable Chief Guest, Dr. K.C. Avari sir, for his valuable presence to grace this occasion and giving great insights for the near future of these budding researchers. I also extend my gratefulness towards our today's presidents or this president of this program, Professor R.K. Kamath sir, Dean, Faculty of Science and Technology. And he has given a great insights as well as a positive direction for the budding researcher and the zoologist in near future. I also thanks to the various speakers. Again, they are delivering their valuable speech throughout this lecture series, but they are still present, be present here in this program. Dr. Manoj Borkar sir, Dr. B.R. Savan sir, I'm thankful they have taken their time for their lecture as well as for this inaugural program as well. I offer my great thanks to our head of department and convener of this lecture series, Professor A.A. Deshmukh sir. He has been continuous in connection, especially for planning and design of this lecture series. Also for suggesting the different aspects for making this lecture series very beautiful and informative as well. I also take this opportunity to thank Dr. S.M. Gaikwad sir, organizing secretary of this lecture series. He has taken a continuous efforts for organizing this different kinds of the lectures, for organizing this online platform, as well as making a smooth going of this program. He has dedicated all the time and remain here for the various time spans for going smoothly and arranging this program very nicely. I thank all other dignitaries here present for this program, various teachers from the different kinds of different colleges, different institutions. I also thank all the participants who are participating from their places, out of the state, out of the country, and from different colleges as well. I also thank to the different students from the other departments as well as from our department. They are being with us for this program. I also take this opportunity to thank all the faculty members, teachers and non-teachers, non-teaching staff as well for continuous support, all kind of the support to happen this program and grand success of this program. Again, I extend my thanks to all those who have not been mentioned here, and they are continuously been here for the success of this program. Thank you once again for giving me this opportunity for proposing the vote of thanks. Thank you, sir. Thank you very much. Over to Bilavi, sir.
Thank you, Gopinath sir, for your beautiful vote of thanks. Now, with the kind permission of the dais and the organizing secretary and the convener, should we proceed to the keynote address, sir?
Yeah. Thank you so much.
Okay.
Yes, sir.
Shall we proceed to the keynote address, please?
Yes, sir.
Okay, thank you very much, sir. Okay, now once again, I welcome Dr. Kersey, sir, for his keynote address. For the August gathering, I would like to introduce Dr. Kersey. Dr. Kersey is an embryologist. He has published a number of books in the national and international journals. Teaching experience at the postgraduate and the graduate level in the subject of the developmental biology to the students of the life sciences. His chief area of interest includes assisted reproductive technology, application support and troubleshooting, cryobiology, electron microscopy, and cytology. He is currently working as a founder director, Embryology, Academy of Research and Training. He is a consultant freelance embryologist, application support specialist in the artificial reproductive technology and embryology and the cryobiology, chief instructor at ART, trained doctors from all over the globe. Work in the collaboration with the various doctors in India and abroad as a super specialty fields. He has been invited on the various talks to be delivered in the field of the embryology and national and international levels of the symposia and the conferences which are related to the embryologist. His specification includes human embryology and assisted reproductive technology. With this, may I request Dr. Kersey sir to deliver his talk in the capacity of the keynote address, please. Over to Kersey sir, please.
Yeah, so I'll start sharing my screen. Tell the host to allow me to start my share my screen, please.
Yes, sir. Yes, sir. Just a minute. Yeah, now you can share your screen, sir.
Yes. Can you see my screen properly, clearly?
Yeah, sir.
Yes, sir.
Yeah. So I think we start with this infertility and enigma, its cures and causes, and its advances in assisted reproductive technology. Now, it's a very dicey topic because today, unfortunately, till date, in spite of our integrity and the intellectuality level going up and up, infertility is still considered as a stigma. It is still considered as a crime, or maybe it is still considered as a punishment by God for some XYZ deeds which we had done in the yesteryears. Now, let me give you an example. If we meet a couple whose wedding ceremony or wedding reception we had visited 4 months back, and if that couple happens to interact with us midway, the first question, what do we ask them? Is there some good news? And when they say no, we look so skeptically as if that poor couple has created a crime akin to murder. So this is our mentality. This is our thought process, which we have towards infertility. Agree. Many a times the infertile couple feels shy, pressurized, inundated by social stigma. They don't come out in the open. But now the trends are changing. They are coming out in the open. There are cures available. And what makes this infertility more challenging is that the more and more you wait for it, the more and more you deteriorate yourself. Because this is nothing else but an ongoing cell culture between the largest cell of the body, that's the oocyte, and the most motile cell of the body, that's the sperm. It is definitely age dependent, as how I will discuss with you in my subsequent talk. So with this topic is fragmented into small sections. First, understanding of the male part, the female part, the handling of the male part, female part, and in the end, the techniques which are definitely enhancing the chances of an infertile patient being pregnant. Remember, no ART technique ensures you 100% result. No. We are still today, in spite of all tremendous leaps and bounds in technology, are at a loss in finding out the ideal sperm and the ideal egg, which is gonna give you 100% implantation, leading to a pregnancy at the end of 9-month period. Fine. So with this, I commence my talk because it's a disease of the reproductive system defined by failure to achieve clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. Initially, it was believed that whenever infertility problem arises, the female is always at the end. She is always responsible and the male is always right with him. But no, it's the other way around. Nowadays, even male infertility is rising. And literally, 40 to 50% of infertility cases are with the males. So it's the male factor. Females are normal. Female factor, males are normal. Both are problematic. Both are normal. It's just the psychosomatic stress which is killing them. Because I will tell you as to how the stress impedes the proper functioning of the sexual gametes. So these are the general causes. And remember, infertility affects both men and women equally. Primary, well, when a couple hasn't conceived even once. And secondary infertility, the couple has conceived once, but they are having a problem in getting pregnant a second time. A pie chart showing you causes of female infertility causes of male infertility, and how much percent each affects. Now over here, you can see there is a huge chunk, 34% unexplained. Now, unexplained is a problem because some say there is nothing like an unexplained infertility. It is uninvestigated. So there are lots of avenues in which we investigate, right, the quality of the gametes. We investigate the organs in which the gametes are produced. We investigate the delivery systems. You investigate the endocrine systems, etc., etc. So infertility doesn't mean that we just study the male and the female gamete and the procedure responsible for it, whether it's a timed intercourse, whether it's an intrauterine insemination, whether it's an IVF, or whether it's an ICSI. So the pioneering efforts of two stalwarts, Dr. Robert Edwards and Dr. Patrick Steptoe. One was a gynecologist and another was a physiologist. They are the ones actually responsible for promoting this infertility further down the line.
The host only can mute everyone. Sir, please mute everyone. Then only this echo will stop.
Yeah, okay. Is it okay now?
Yes, sir. It is okay now, sir.
Yeah.
Excuse me, sir.
Yeah.
Huh?
Yeah.
Yes, sir.
Kindly mute yourself. Don't disturb the speaker. So it is kind request to all, mute yourself.
Okay. So this is the biodata of the first world IVF baby, Louis Brown. Now, well, she also is a mature woman. She also is a mother of children. And this is the first biodata of the first world ice baby. Ice baby in the sense frozen embryos, a child delivered from a frozen embryo. And this in a nutshell are the events listed. First IVF baby, first ICSI baby, first IUI pregnancy, and the first frozen embryo pregnancy. So this is how we have progressed down the line. Now, as I said, the two cellular entities, the sperm, mature, activated in a quantity with fantastic progression. Now this you can see progressive motility means they tend to travel quite in a straight line. And this is non-progressive motility, just randomly swims anywhere. So this is not exactly a result-oriented sperm. On the other side, the oocyte, a well-matured metaphase 2 oocyte with a lovely expel polar body, all ready to accept the most activated and capacitated sperm. So, well, these are the two entities, the sperm. What we have to do, we procure the sperm, we analyze the sperm, we culture them, we wash it, we capacitate it, and then we select it. At the same time, the oocyte, the stimulation, the hormonal protocols, the folliculogenesis, the rupture pattern, the growth pattern in the uterus, the retrieval, and the subsequent culture. Now, we target the male gamete, that's the sperm. Usually when we study sperm, it's divided into three parts: head, the genetic package and the DNA, midpiece, energy source, mitochondria, generation of ATP, transmits the energy to the tail, locomotory organ, whiplash motion, effective stroke, recovery stroke. Though the three areas have their specifications listed for them, but for a functioning sperm, all the three should coexist together. So the functioning pattern of all the three areas of a sperm coupled together are responsible for making it an ideal gamete as far as male fertility is concerned. Now, this is what? Morphological criteria. dimensions as per the WHO standard: the head length, the width, the percentage of the acrosome, the midpiece, and the tail. As I said, each is separate, each has a separate function of its own. Now, descriptive wise, what makes sperm a real dynamic structure? Because what it has the DNA. The DNA of a mammalian sperm is the most known compact eukaryotic DNA, which is compactly packaged 6 to 7 times. And it is like a lysosome. Once it enters into the oocyte, it decondenses, it liberates its content. It forms the first sign of life, that's the zygote, which we can call it as an undivided embryo. So zygote is the first sign of life which we can witness in a laboratory under the microscope. Now, what are the hormones responsible? Well, testosterone, it's an indigenous hormone which is produced by the males. The responsible ones, the pituitary gonadotropins, are FSH and LH, because as you know, this is an axis, hypothalamo-pituitary gonadal axis. Hypothalamus secretes releasing factors which targets the anterior pituitary, the gonadotrophic cells. Fic means acting at a site. They target a special organ, like the gonadotrophics target the testes, the thyrotropic targets the thyroid, the adrenocorticotropic thyroids targets the adrenals. So these trophic hormones, prior to puberty, during puberty, and in an adult. And this is the basic backbone of investigation as far as an infertility specialist's role of judging the fertility potential of an infertile couple is concerned. Now, let us have a brief view at the hormonal control. In a nutshell, your hypothalamus secretes the releasing factors, targets the anterior pituitary. FSH stimulates the Sertoli cells, facilitates spermatogenesis. LH stimulates the Leydig cells. Now, Leydig cells are the interstitial cells between the two tubules. They are also responsible. Secretion of testosterone. Now, this testosterone also has a negative feedback effect. The high level of circulating testosterone in the body itself is responsible for giving the signal to the hypothalamus and the anterior pituitary to help it control the levels. Because initially, if we are given testosterone injections, initially they do stimulate spermatogenesis. But as the circulating level increases, it acts like a natural contraception. It will improve the muscle mass of the body. But at the same time, excessive overburdened use of testosterone will make our testes slowly shrink. Hence, it is a very important parameter when gentlemen coming for investigations with lovely bulky bodies and bodybuilders, the first thing we ask them that, sir, were you on steroids at that certain time? They say yes, but they say it was very controlled. But at that moment of the time, they were not sure how much in control it was, whether it has led to a permanent suppression of the axis. So now the return to normalcy is a little bit under the question mark. Now, these are the stages, right from the spermatogonia, the primary spermatids, the secondary spermatids, spermatocytes, the 3 stages of spermatids, early phase, cap phase, maturing phase, and ultimately the spermiation. The length, 70 days. It takes approximately 70 days for one spermatogenic cycle to be complete. A cross section. Now, before the advent of this radioimmunoassays and the hormone estimations, what we were doing? We were doing testicular biopsies. Just take out a tubule, paraffin fixing, hematoxylin eosin observation, 5 microthin slides, observe them. We used to study the stages at which they were arrested or they were propagated. There used to be a testicular biopsy score ranging from 0 to 10. It was only the Sertoli cell functions or normal spermatogenesis which showed all the stages of spermatogenesis and a lovely accumulation of sperm into the lumen. Now, we used to count something like 100 tubules, out of which 60 should be showing normal spermatogenesis, because the rest of the 40, they undergo a state of rest, only to become active in the subsequent spermatogenic cycle. And accordingly, we used to grade how many are arrested, at what stage they are arrested. And care and caution was taken that when these reproductives are biopsied and fixed, they need to be fixed in a specialized fixative, what we call as Bowen's fluid. Neither is absolute alcohol needed, nor is 70% alcohol needed, nor is formalin, because these will lead to the shrinkage. And this shrinkage of tubules will cause a difficulty in the histopathological investigations. Another important part, when the spermatogenesis takes place in the testes, we all must have seen that the testes are situated in scrotal sacs, which are outside the body cavity. Why? Because of the temperature. It cannot survive at the body temperature. It has to be 1 to 1.5 degrees less. Now, there is only one terrestrial mammal which has the testes inside the body cavity, and that is the elephant. The elephant has the testes inside the body cavity because it is insulated by layers of fat. Because this temperature variation is also crucial as far as, I think somebody's mic is still on. It's creating a lot of disturbance.
You will have to again mute everyone as a host.
Okay, ma'am.
Gaikwad sir, mute to everybody. Gaikwad sir.
This is extremely disrespectful to the speaker. You please remove the person, whoever it may be. Remove the person.
Sir. Exactly,
very disrespectful.
Sir. Yes, exactly, sir. Gaikwad sir.
Gaikwad sir will not be in position to do because he is not the host. Only Kersi sir is the host.
No,
Yes,
Dr.
yes,
Kersi, you please remove the person, because despite several requests, she seems to be incorrigible. Just take her out.
Join that meeting.
Dr. Kersi sir, I request you to remove that particular fellow.
But unfortunately,
Yes,
I can't track
exactly,
him. I can't track him. I can't track him.
Sir, please call her personally.
No, Bogil. Her name is Bogil. You can find in
Yes.
participant.
Please.
Just a minute, sir.
No problem. So take your time. I think now it's okay.
Kersi sir, what you can do is you can make someone else as a co-host.
Yeah, fine. I'll make someone else as a co-host. Yeah.
The person will immediately mute the person who unmutes the mic.
Fine. Okay. Okay, so who's ready to be the co-host?
Sir, let it be from the organizer's side.
Sir, either you can make me Ashish Deshmukh or Dr. Sunil Gaikwad as co-host. Any of us.
Any one of you can take over, not any.
Yeah.
Is there? Just saw her in the office just now. Morning also I saw her. She was looking at me like that. All of them actually.
Excuse me, sir. Kersey sir.
Yes, sir.
I will reclaim the host and later on I will make you host.
No problem, sir. Carry on. Carry
Yeah,
on. Do
yeah.
that, please. So shall I start sharing my screen?
This is the problem when we offer free webinars.
Yeah.
Yeah, that's very true, sir. That's very true.
Okay, I'll start sharing my screen now.
No, sir. Just wait.
Okay, sure. Not an issue. Not an issue. Take your time. 1 or 2 minutes then gonna make a difference.
आता मी कुणाला अलाउच करत नाही. Yes, sir. Now you can start.
Fine. Yeah. Am I loud and clear? Hello?
Yes, sir.
Yeah, fine.
Yes, sir.
So
Yes,
this
sir.
is what we were discussing, that in terrestrial mammal, only the elephant has the testes inside the body cavity because it is insulated by layers of fat. Now you will believe how much important the heat concept is, because that is one of the main reasons that when we investigate the male and we ask for the history, many a times those have a habit of absolutely wearing tight underclothes, those tight skin tight jeans, sitting cross-legged for hours together with hot laptops on their laps, or the rickshaw drivers who sit on the heated engines. Heat does affect spermatogenesis and does compromise their motility or the kinetomatics also. So heat plays a very important part as far as being a very valuable parameter for the investigation of male infertility. Now, well, we all know spermatogenesis. Now, spermatogenesis, the different steps by which spermatogonia are transformed into spermatozoa, it takes at puberty and it continues lifelong. They may be feeble even at 64 years, even at 70 years, occasional residual sperm. So the whole process is called spermatogenesis, spermiogenesis, wherein the spermatids differentiate into spermatozoa, and spermiation, the release of sperm from seminiferous tubules transported into the vas and then to the epididymis where the maturation occurs. So let's think about the 3 steps. Now, I target the female gamete, the oocyte. Well, ideal oocyte, the oocyte cumulus complex, in which the mature or the immature egg, I don't know, is surrounded by cumulus cells, or what we call it as a receptive cumulus. When the oocyte is mature, the cumulus are receptive, fluffy, hormonally primed, because the polar body is extruded outside. And this is known as an active metaphase 2 oocyte, which in figure will be looking like this. The granulosa cells lovely expanded, and in the center, the oocyte. Now, till the time they are in the OCC complex, we are not in a position to judge the integrity or the maturity of the development. It is only when we denude these granulosa cells will we be able to know what is the condition of the oocyte. Number 2, the crude parameter by which an embryologist, just by scanning the OCCs, can come to a conclusion, a part conclusion, that, oh yes, this looks like metaphase 2 because The granulosa cells are fluffy, they are hormonally primed, they are well expanded. So the probability of this mature metaphase 2 is higher. If the granulosa cells are tight, compact, well, the chances of the quality of the oocyte is poor. It may be metaphase 1. Now see, this is the polar body which has extruded outside. So when I would say I want a good quality oocyte, means the cytoplasmic content should be perfect, color uniformity there, no vacuolation, no pitting, no granular accumulation, small perivitelline space, a very well expelled pronuclear, zona complex. But remember one thing, oocytes will come in the stage and oocyte will come as a grade. Now this is a metaphase 2 stage and grade 1. But in case of elderly ladies, post 34, the quality and the quantity of the oocytes take a dip. They take a dip means what? The functionality is bad. They are not well progressive. Viability is compromised. So many a times when we see the polar body very large and big, disproportionate in size, it is aneuploid. And aneuploid oocytes are a disaster because they may be the stage, but the grade may be grade 3 or grade 4, which are as good as useless. So this is known as judging the oocyte morphology. Now this in a nutshell, I will just show you the anatomy. Well, starts from the urethral path, the clitoral path, the pubic symphysis is over here. This is the entry part, the vaginal opening, the vaginal canal. This is the internal os, this is the uterine, this is the uterine mid cavity. From here we'll be extending the two tubes, lovely muscular bag, the fundus of the uterus, the fornixes. So this is all we have to judge clearly, properly by ultrasonography prior to the patient being recruited, because in male, it is simple. Just the quantity, quality of sperm which are ejaculated, because sperm can be delivered at any time. Male gametes you can handle easily, you can play with them, you can manipulate them. Whereas in a female, they are less. The female has a role, dual role. They produce the female gametes, mature them, liberate them. In the accessory glands, that is the tubes. These will come across. The sperm will come here. The sperm will migrate. It will meet here. It will fertilize. The uterine tubes has to accommodate the conceptus. Charge it all the way down the tubes into the uterine cavity. Help the embryo grow. Form it to the blastocyst. Implant. Once the implantation takes place, it has to carry it to term. There are different axes. Then we'll start the uterine ovarian axis. Pregnancy, 9 months gestation. So a female has a loads and loads of more things to be done compared to the male, in which he just produces and delivers sperm at ease. To retrieve a female oocyte is an intrinsic procedure done under GA, what we call it as ovum pickup or oocyte aspiration. So this makes this field a little more challenging. So this is a generalized view of the ovary, whereas we see all the follicles in various stages of development, starting from primary, the developing follicles, ultimately the Graafian follicle, which is mature, which is also under hormonal control. It ruptures, it is released, it is trapped, it is fertilized, and the embryogenesis commences. The leftover part, the corpus luteum, if the embryo formation doesn't take place, it goes into corpus albicans and subsequently merges with the ovarian stroma. If pregnancy is there, it is activated thanks to the secretion of progesterone and the HCG. There will be a synchronizing effect between the ovary and the uterus, which I will tell you. HE slide. What do we see? Different stages of oocytes. See the different layers which are being added. The zona pellucida, old follicular cells, primordial follicular cells, the thecal layers. So it is a bag or a mass of proliferating cells completely under the hormonal control, thanks to the anterior pituitary, thanks to the releasing factor from the hypothalamus. This is in a nutshell a smooth pattern or a smooth developmental pattern for the primordial follicle all the way towards the ovulation. These are the developmental pattern, and at the same time, the cellular pattern which takes place. Now, we studied the male part. Now here we are studying the female part. Hypothalamus targets the pituitary, follicle stimulating hormone, luteinizing hormone targets the ovary, follicles are produced. Then there is a slight negative feedback of the estrogen and progesterone both towards the pituitary. Ultimately, they are the ones who not only produce the follicles or the ovaries, they are also responsible for the maintenance of the uterus and the uterine condition, because this is the celestial bed where your subsequent embryo is going to implant, it is going to denude, it is going to mature, it is going to grow for 9 healthy months, what we call it as 3 trimesters of pregnancy. So this is the hormonal control. Well, how it acts. The Graafian follicle about to mature, the LH surge, it fires a trigger, the follicle ruptures. Now, all these formulations or all these hormonal mechanisms are controlled by us exogenously when we recruit a lady for an ART treatment. So this procedure compiles of patient selection, patient stimulation, dosage selection, ovum pickup, and then subsequently the other side of the fence, that is the embryological aspect, where the embryologist receives the cohort of eggs, a cohort of sperm, and depending upon the indications they do, whether it is IVF or whether it is ICSI, or if normal conditions are there, a very simple procedure, what we term it as intrauterine insemination, in which we are handling only one part of the gamete, that's the sperm. Now, this is the developmental phase of a follicle, the pre-antral phase and then the antral phase. Now, when the antral phase is there, it is very important because there the maturity complex starts. So this is known as the pedental. Now, when the LH surge is given, this pedental will activate, the oocyte will dehiscence, granulosa will become loose, and when the ovum pickup is done by passing the needle through this, the ovum is aspirated. The procedure, what we call it is ovum pickup or egg aspiration. This is the detailed structure. Antrum cavity or the follicular fluid cavity, the follicular cells, the ovum, the cumulus oophorus. Now today, imaging technology has grown sky high. We can measure the diameter. We can measure the proliferation. We can measure the blood flow pattern, the systolic and the systolic diastolic blood flow. In that way, we can imagine, we can measure or we can justify the qualitative and the quantitative content of the follicles in each ovary. So therefore, as far as female investigations and priming are concerned, folliculogenesis, sonography, and folliculometry are the backbone. Now, how your hormone levels and follicular development start. Initially, what is responsible? FSH. Then where is LH given? LH is a trigger or a surge which takes place, and this bingo, it pops out the oocyte from this follicle. And this is there. Once it has popped out, LH goes flat. Now, in the event of implantation, what takes over? Progesterone. So the progesterone peak rises. So this is how it synchronizes. The developmental pattern, the rupture pattern synchronizes with the hormonal flow. So in case hormone analysis being done, if it is a little haywire, so cycles are primed, cycles are stepped together. So when is the lady most fertile? On the 13th, 14th, 15th day, when the follicle is just about to rupture. And how will she know? By the surge, by the change in the basal body temperature. So these are all parameters which are being discussed. And nowadays we get the regular kits to see whether the LH surge is there. So when the LH surge is there, she is prime, about to rupture, most fertile, high chances of pregnancy are there during this time. So this is exactly what an LH surge takes place. So this is the typical day of ovulation. Okay, so this is a synchroning pattern of the follicle development, what happens during an LH surge. And by ART technique, LH surge is what? We give an exogenous injection of HCG, because this mimics the LH surge, because the pituitary secretions is completely cut off. We are taken the complete stimulation of the pituitary into our hands, which is known as a protocol. Now for developmental biology students, just to tell you that the endoderm and the mesoderm are mostly responsible for the formation of the gametes, because then the cells form, they migrate, they assimilate, they differentiate, and then the organogenesis sets in. Now, a little, since we have discussed the male and the female gamete, now I target again a little bit on the male infertility. Now, well, male infertility is a mixture of two issues: spermatogenic disorder and erectile dysfunction. Now, spermatogenic disorder means the production of the sperm is pathetic or bad or suboptimal. But erectile ejaculatory, absolutely normal. A gentleman can consummate his marriage, have sexual satisfaction, but the content, the seminal content which he delivers is not up to the standard. Therefore, this leads to infertility. Now, in erectile issues, a person is normal spermatogenesis, production is good, sperm quality, quantity is excellent, but unfortunately, he cannot consummate the marriage. So this is where the ART techniques also come into play. So male infertility is a complex issue. Why? Because a male should have healthy sperm, number one. The sperm should amalgamate into the semen or the seminal content. There should be quantity and there should be quality. So therefore, the most important two parameters for male investigation are the count and the motility or the kinetomatics. Then there are other medical causes: varicocele, infection, ejaculated issue, tumor, undescended testes, chromosomal defects, hormonal imbalance. Environmental causes are there, lifestyle causes are there. And this obesity is now universal with every problem which any individual faces in any field of medicine. These are the reasons. At the pie chart once again. Now, well, there can be a vas deferens block. See, the sperm are produced, epididymis are normal, caput corpus cauda, both are functionally normal, secretory capacity is perfect, but the delivery pattern is compromised somewhere over here. There is a block over here, and this is known as obstructive azoospermia. Means the sperm are not given or getting a chance to be ejaculated outside, they are obstructed. So it is called obstructive azoospermia. Then there can be a case of undescended testes, Wolffian ducts problem. There can be a case with varicocele, whereas in the pampiniform plexus, the spermatogenic artery and the vein are clumped together. The vasa deferens is trapped. So the sperm pathway is obstructed because of the swollen veins. Then many a times people undergo vasectomy and then they do a vasovasotomy, they do religation of the cords. But unfortunately, it is not all that successful. Then there are ejaculatory disorders. It can be premature, it can be delayed, it can be retrograde, or it can be total anejaculation. Well, ejaculation, the ejection of the sperm and the seminal fluid during an orgasm in a male. Now, this is the responsive cycle. Initially, there is excitement phase, there is lubrication phase, then there is a little plateau, then suddenly there is an orgasmic phase, ejaculation, and then there is a flaccid phase or a resolution. So these are the 4 steps when a male delivers the semen during a sexual intercourse. And this is the role played by each and every organelle. And this is the pathway as to how they travel: the sperm, rete testes, maturation, order, storage, vas deferens delivery, enter the accessory gland complex, the seminal vesicle and the prostate. They give their secretion, because remember, seminal vesicle and prostate rich in alkaline phosphate, zinc, fructose, sialic acid, and sperm respire anaerobically. So ultimately what the amalgamate comes out is a semen. The sperm suspended into the secretions of seminal vesicles and the prostate. Seminal vesicle contains of 85% by the volume and prostate is 10%. The rest of the 5% is a mixture of the prostate, testicular secretion and the epididymal secretion. Then there is premature ejaculation. Premature ejaculation is when you have an orgasm before intercourse or less than a minute after you start. You immediately ejaculate and suddenly you lose your erection after that. So there is no sense of the success feeling. Actually, andrologists or ejaculation specialists have seen when measured on a stopwatch, it takes an average of 5 to 7 minutes for a man to reach orgasm and ejaculate. But the range is sometimes wide. So this is a big question mark. How long should a man last before an ejaculation? So there was also another study, intravaginal ejaculatory time. In premature, less than 1 to 2 minutes. In normal, between 4 to 10 minutes. In delayed, 20 to 30, or in anejaculation, unfortunately, the feeling is there, but the ejaculate doesn't come out. So anejaculation or aspermia. Azoospermia means no sperm in the ejaculate, but the ejaculate is present. So these are all the criteria which we have to literally deal with an andrologist. So this is delayed ejaculation, also called impaired ejaculation. It's a condition which takes an extended period of sexual stimulation for men to reach a climax and release the ejaculate. I think there's some more disturbance once again.
Pratiksha Sell, who is, she is remove. Pratiksha Sell.
Remove Pratiksha. Remove Pratiksha Sell.
Sir, you can remove her, please. It is not for the first time she is unmuted herself.
Gaikwad sir, remove her.
Host,
Gaikwad
please
sir.
remove her.
Kersi sir.
Yes,
Kersi
sir.
sir. Just a minute.
Pratiksha Sell.
Pratiksha Sell.
Who is?
Yeah, she has unmuted
Now
herself.
she is unmute. Okay.
Yeah, fine. Anyway, so when a problem with this occurs, then it is like it is delayed ejaculation. And sometimes men with delayed ejaculation are unable to ejaculate at all. Now there is anejaculation. Now anejaculation is what? When you just can't release any ejaculate, or it is known as a dry orgasm. Okay, fine. So these are all the problems which can be there in the male. It ranges from the sperm content, the sperm delivery pattern, the sperm expulsion pattern, the timing and the manner in which they are expelled. So this all complicates the issue because this is such a sensitive and an emotional field that once a gentleman comes to know that he is having a problem with this, psychosomatically he is so stressed out that in spite of giving him regimens of therapy, he just fails to come back onto his normalcy. So the first step as far as treating a person in infertility is concerned is that you have to console, convince, and reassure and reimpose the faith in the poor gentleman who is suffering from some anxiety related disorders or depression related disorders. Then, well, there are some other reasons. There are genetic defects. There are Y chromosome microdeletions. So all this needs to be investigated. It is not that I get the sperm. So that's the reason wherein many places, the semen reports which we get, well, are not to be fully trusted XY, because a semen report is a thing which a reputed andrological laboratory will be doing it, not in a routine pathology laboratory, because there are so many questions, tips and tricks to be asked for. The number of days of abstinence. Did you have any illness? Did you have a fever? Are you a chronic smoker? Are your previous problems? There is a lot of things to be investigated. Was your collection justified? Was there a spillage? Were you able to collect the whole of the ejaculate? So, it's a battle between the physical performance and the mind and thought. I would say the mind at peace and at ease in this procedure is excellent, because this is not simple blood collection wherein you push in a hypodermic and pull out the blood, put it in the autoanalyzer, and bingo comes the list of reports. So this is where I trust the dedication of the semanologist to be of utmost importance when he or she sees or justifies a semen slide under a microscope under various magnifications. Now, we jump to male infertility. Well, problems are many. Ovulation, where they are produced, fallopian tubules, from where they are transferred, uterus cervix, acceptance of the sperm, lovely endometrial cavity with the budding in layers as a receptive bed for the future embryo. And the most important problem with female is the age factor, because along with age, fertility takes a dip. So 34 years or 35 years plus, the female infertility criteria takes a dip, because the whole hormonal network goes for a toss. Most important, diabetes, thyroid, obesity, age factor, hypertension, all are amalgamated, and anything wrong with the normal body functioning inadvertently casts its lethal shadow on the fertility issue. So people always ask that when I have an LH surge, I may not be ovulating. So all the ladies who have periods, that doesn't mean that they have ovulated during that time. This can be also an unruptured syndrome or luteinized unruptured follicle syndrome, LUFS. Okay, so some women also experience small peaks of hormone LH, especially in polycystic. So basically, LH surge is of prime importance. It will help us detect the timing of ovulation within that small window of 12 to 24 hours. Now, ovarian disorders. The most common symptoms: irregular or absent periods and difficulty in becoming pregnant. The causes: PCOS, polycystic ovary syndrome, hormonal imbalance, primary ovarian insufficiency. Now, this is the forte of a gynecologist. So I would tell you, all infertility specialists are gynecs, but all gynecs are not infertility specialists, because infertility is a separate offshoot of a branch which deviates from the normal gynecology scenario, and we have to specialize in that. So even infertility is a branch, it's a wall, the clinical findings and the embryological findings. So a clinical part, the doctor gives you the lovely oocytes and the sperm, the embryologist takes it, amalgamates them into a lovely embryo. Now, age. Women are born with a lifetime supply of eggs during the early gestation. As the age progresses, even when they come towards puberty, hardly a fraction of eggs are left. Fertility actually declines at 27. That's a very harsh definition, but significantly declines at this age. Because you see the content of good follicles in an ovary, and out of the viable pool, how many are viable? If there is a large pool, 50% are viable. Reduced pool, 67. More reduced, hardly 33. So this is what we call it as ovarian reserve. So ovarian reserve is also a parameter in which we judge the infertility of a lady. She is a poor producer or a very poor ovarian reserve. Means the conglomerate or the content of the eggs are less. Even the eggs may be 5, but how many are worth proceeding to the actual maturation phase? Now, this all will be done by a lovely jugglery or an intermingle of the folliculogenesis by ultrasonography and your hormone estimations. Now, decline in fertility with increasing maternal age. What happens? As the age advances, the errors in the dividing embryo increases. The age results in the aneuploidy. These are certain ovarian tests which are being done prior to the patient being recruited for an ART cycle. The AMH, the antral follicle count, means the tiny follicles which remain in the ovary prior to the lady being recruited for a next cycle. Because by this time, the pituitary supply of gonadotropins has been cut off by dupride, so the ovary becomes redundant, and subsequently we take the ovary into our own hands and we administer exogenous injections of the hormones FSH and LH, mimicking the secretion which would have otherwise taken from the pituitary. We monitor the growth, we monitor the hormones, and then we can say whether the stimulation is going as per the schedule. There can be flare-up of follicles, there can be just poor recruitment, there can be just poor development. So all these steps are necessary, which can also initiate a cancellation of your ART cycle. Now this is what, see, and anti-Mullerian hormone is important. Why it is important? Because it suggests a very good ovarian reserve. This is the values. Ideally, it's a very good marker to prove the productivity of the subsequent oocytes or the eggs which we are going to retrieve by ultrasonography. The causes, anovulation causes, and premature ovulation failure, early menopause, decreased estrogen, very high levels of FSH, autoimmune reasons, genetic and idiopathic. There are hardly a feeble chance, 1 to 2% pregnancy chance when ART cycles are done in patients with premature ovarian failure. Now, when we investigate, what is the first thing we do? We study the ovaries, right? But then most important, we have to study the functionality of this tract, which means the fallopian tubes. This is a lovely incubator which takes care of the development right from here, release of the egg, the sperm fertilizing the egg, formation of the zygote, cleavage 2-cell, 4-cell, 6-cell, early morulation, late morulation, compaction, 3 steps of blastula, popping into the uterine cavity, subsequently implantation. So your tubes have to be open and functional. There are 2 issues. Because functional tube, why? Every area of this tube has its varied cytoarchitecture, and each cytoarchitecture is responsible for specific secretion at a specific time, because the embryo will start developing fast. Minute to minute, the needs increase, its requirements increase, its metabolism increases. So remember, open tube doesn't mean a functional tube. These are the 3 areas: infundibulum, ampulla, and isthmus. This is when the LH surge comes in, the tubes or the fimbria get activated. They cup the ovary here, from the hyla. The rupture will take place. The oocyte will be sucked in, subsequently fertilized, and the procedure will go on. Now, there can be chances of tubes infection, mostly chlamydia, sexually transmitted diseases, bacterial infection. This is how your cervix looks in a normal condition. This is the external os which is over here. And this is the cervix which is infected by chlamydia. These are the symptoms. Okay. It has to be treated, or it can be treated with antibiotics, provided it is detected early. Or else, unfortunately, this can spread to the other parts of the body. So what do we do for the tubes? We do is a hysterosalpingography or the HSG test. Now, HSG test is what I'll show you. We inject a dye from here. And under scanning or the X-ray pattern, we see whether the spillage of the dye comes out all the way from the tubes, which will tell you that the tube is open. If there is an improper expulsion out, the tube will be blocked, so the dye is not spilled out. So we can say that this is a blocked tube. But remember, as I told you, an open tube doesn't mean a functional tube, because functioning means what? Clear passage plus the secretory capacity is ideal. Now see, the radio dye highlights the uterus, the fallopian tubes. You can see how it is completely, and the spillage takes out from here. Now another phenomena or a problem is hydrosalpinx, water accumulation due to infection. Well, surgery is there, antibiotics are also there, but as I said, earlier the better, because it will form later on scar tissues, adhesions, etc., and all will be compromising the development of the embryo, the transfer of the embryo, and the health of the embryo. So this is what hydrosalpinx will be looking like. See, now this is your uterus, this is your tube, this is the ovary, and this is the swollen part. Left hydrosalpinx, right hydrosalpinx, because the contaminated secretions will come and will accumulate into the uterus, thereby contaminating the whole uterine endometrial cavity, compromising the receptivity of the endometrium. You got my point? Now you will say that, oh, in an IVF, I harvest the oocytes from here and I transfer the embryos over here. What are they going to be of a problem? Well, the contaminated secretions spell havoc. The whole area or the whole uterine bed gets compromised. So there is no chance of you getting an implantation. So whenever such problems are detected, they have to be corrected first. So when the patients come to you, they're always in a spot of a hurry. We tell them that, listen, you waited for such a long time. Why not wait for 6 or 7 more months in order to help us improvise the findings or improvise the what you call the actual investigations? Then they also question, procedures are expensive, but the success rate is somewhere between 28 to 34, the take-home baby rate I'm talking about. We tell them that, listen, had the treatment not been done, you are not also in the 30 category. You would have a 0 chance of getting a pregnancy. Here we are enhancing those 30% chances furthermore for your convenience. So this is what I said. A functioning tube doesn't mean a normal tube. Now, there are remedies for blocked tubes. Now, there can be adhesions, there can be recannulization, there can be a wire-guided opening of the tube, or there can be a reanastomosis. Now, your uterus. There are inclusions or non-cancerous growths in the uterus, which sometimes appear at any time. Lyomas or uterine fibroids. Then there are polyps. Now, polyps are growths which can be attached anywhere, inner wall, outer wall, in the endometrial cavity. So they are also divided. Now, see, this is what exactly I wanted to show you, how the polyps look like and where all they go. If it is outside, pedunculated, it's like a pedental hanging. Internal pedunculated submucosal means inside, subserosal in the wall, intramural. Now, those ones which are inside, they compromise the area, and this is exactly how your fibroid uterus will look like. Now, as per the FIGO classification, this is how they classify. This is a little more from the gynecological viewpoint, and depending upon the position, depending upon the size, and depending upon the growth, how much of a problematic nature they could be. Now, this is exactly what I wanted to tell you. 100% intramural, beautiful inside. It's a little part, subserosal. Now, it may be at a safe area, but it may gather a large area. So this is all first what needs to be resurrected before assigning an ART cycle to any patient. Now here exactly on the sonography, how it looks. Now, this is the one which we have targeted. And this is exactly how it looks on the sonography. This is the uterus. This is the uterine cavity. And this is where it is nestled across over here. Got it? The same is over here. Over here, this is over here, and this is the one which we are focused. It comprises a safe zone because this is your uterine cavity, and this is where your embryos are going to nestle once they are transferred atraumatically into a healthy, receptive, trilamellar proliferating endometrium. Now there can be problems with Mullerian ducts. What happens? So we also encounter Mullerian anomalies. Now this can be like this: a normal uterus, a didelphus, common entry, two separate parts. Most important, or many a times we see is a septate uterus. So what we do is, by surgical, we remove the septate dissection. So this septate is cut off from here, increasing the cavity over here, and thereby enhancing the chances of implantation. So these are all organ anomalies. Why are these important? You may have an excellent oocyte, you may have an excellent embryo, you might have an excellent, but the place where the conceptus is going to encourage itself, if that is problematic, then unfortunately the whole procedure of your embryo culture is going to go waste. And therefore, in certain ladies with severe thereby the concept of surrogacy started. Surrogacy is that I am lending my womb on hire. But now ICMR has come with strict guidelines as far as surrogacy concept is concerned, the oocyte donation concept is concerned, and all the other sharing concepts are concerned, which I will not be touching in this. Now what is here? Endometriosis. Most important, painful part. A disorder in which a tissue similar to the tissue that normally grows inside of the uterus grows outside. Now this is the schematic diagram. Okay. Now this will consider a high risk pregnancy. If a pregnancy occurs in a patient with endometriosis, of course, she will be having a difficult time to conceive. But once conceived, the gestation completes or continues, then it is considered as a slight high-risk pregnancy. And most important, PCOS, polycystic ovarian syndrome. Excessive male hormone levels, number of follicles, poly, but not functional. They go bad. They form cystic. They are not capable of delivering the result. So these are the treatments. These are the symptoms. Okay. Now this is a very nice ultrasonography. Now see, this is a classic chain pattern. All tiny, numerous follicles have developed over here. But what will happen? They won't grow a rupture. They will just keep on growing like this, and ultimately form a cyst like this. This is your uterus, the tube, and this are the big rupture, big cysts, unruptured. So when we puncture them, we get chocolate-like aspirate. So these are known as chocolate cysts, because the follicle aspirate, which is usually light straw yellow in color, this will be with dense brown chocolate-like fluid. So how will we investigate? We do a laparoscopy or a diagnostic laparoscopy, which is used to examine the organs inside. Now here it is encephalated by medical grade carbon dioxide. A trocar is inserted. There is a light source, and everything is studied prior to it. So it is laparoscopy, or subsequently it is hysteroscopy, wherein a thin probe wire, it is inserted with a tube light into the vagina to continuously examine all the inner cytoarchitecture of the endometrium, the cervix, the health of the cervix, and the vagina. So there was a question: do all ladies undergoing this ART have to be investigated? Well, yes and no, because we are knowing the external, we are knowing the hormonal pattern, but we are not investigating inside as to how the scenario looks interior of the organs. Because the sad part is, oocytes rupture, they are inside, sperm are produced, they are expelled outside. So we have a lovely chance to interact with them, to study them with more tenacity and depth than compared to the oocytes. Because once the oocytes are out from vivo to vitro, The most important part is to culture them because they are osmotically very sensitive. They are sensitive to temperature, they are sensitive to pH, they are sensitive to osmotic stress, they are sensitive to environmental conditions, epigenetic factors. And the quality of an otherwise actual well-formed uterus, oocyte, can suddenly crash down because of suboptimal working conditions. That's the reason an ART lab has to be primed to perfection, because it is mimicking our actual uterine environment. Handling the sensitive gametes from vivo to vitro is a challenge. Now, this challenge has to be overcome by the embryologist. Number one, I'll tell you in the subsequent thing. So, what do? Patient selection. We stimulate the patient. We do an ovum pickup. At the same time, andrology does sperm preparation. We either inseminate by an IVF or inject in an ICSI. We culture the embryos. We transfer. If there are extra, we do cryopreservation, and we give a postluteal support to the lady in whom the embryo is transferred or the sperm is delivered in an IUI procedure. So your ART consists of 3 vital steps: recovery of your gametes, the survival of your gametes, and the viability, means the way in which they progress further. What are we? We are still the ongoing cell culture, which started minus our age, minus our 9 months of gestation, when we conceived as a zygote. And touch wood, by the grace of God and mercies, we are still progressing. We are developing. Why? Because at that time, the ideal sperm and the ideal oocyte had met. There were ideal conditions. So it is said that in embryology, why are we able to handle only the first 5 days till the blastocyst? Beyond that, it's not in our hand. Because once the blast develops, the inner cell mass and the trophectoderm, then it will slowly denude the endometrial cavity. It will implant. It will burrow. And we are hemochorial. We bleed. Our placentation is hemochorial. We develop primary, secondary, tertiary villi. Once implanted inside, post an embryo transfer, it nestles down. After the 15th day, it will become its own endogenous endocrine organ, and it will release HCG, human chorionic gonadotrophin. And we measure the beta subunit, which is very sensitive. So the presence of that beta subunit HCG in the blood gives us an indication that, oh, that fellow was implanted, because there the environment is also changing, the cytotrophoblast and the syncytotrophoblast. Now the secretion of this beta HCG gives a signal to the ovary, to the corpus luteum. Please don't go into corpus albicans, remain as there. I want progesterone from you. So now we'll start the synchronization between the ovary and the uterus. Now the high level of progesterone in the blood will give a signal to the pituitary. Please, I don't want any more follicles. Stop the secretion or restrict the secretion of your FSH. So this is nature's contraception. Because at this time, another hormone will kick up, the lactating control hormones. So the presence of that, that's why they say in India, when mothers breastfeed their children for 2 to 3 months, it is a natural way of having a contraception. So what is infertility and what is the treatment? It involves an intricate study of the amalgamation of all hormonal interplays. So my humble advice to all students, when you want to enter this field, be thorough with the endocrinology of male and female reproduction. Because along with that, when we handle the 2 gametes, the 2 techniques, IUI, IVF, and ICSI are being done. Now, a brief introduction to what we call it as your stimulation. Normally, we produce 1 oocyte. But in the procedures, we want more. Because the more the better, the more the merrier. So when we exogenously give the injections, this is how the pattern starts. The follicles are recruited. Then low dose gonadotropins are injected, so they mature. Then they dominate. And then ultimately the Graafian follicle comes in. Now you see a slight reduction in the number because all which are recruited will not form into the proliferation. So in an IUI, first what it was, natural cycle, just inseminate the sperm, very pathetic success rate. Then they were given exogenous clomiphene citrate. Well, rate shot up. Then clomiphene citrate plus human menstrual gonadotropin. Well, rate still shot up. And then as we keep on improvising with the hormones, we give highly purified gonadotropins. Okay, definitely. The quality and the quantity of the eggs do increase because in an IUI, we are not seeing the oocyte at all. We are just judging in the morphometrical appearance of the ultrasonography. So this is how your ovaries will look, a stimulated ovary. Look at the number of follicles. So you can see a follicle, but you cannot be assured of an oocyte inside the follicle. And surrounding the follicle over here will be your granulosa cells, which will secrete estrogen, a derivative of which is estradiol, which we measure to bring about a synchronicity between the estradiol level and the growth phase. So this is a sonography machine. It has got the probes, the abdominal probe, the vaginal probe, and very sensitive. And this is the principle. It transmits high frequency megahertz sound waves. The waves go and they reflect back. It casts an image. So the image is like a triangular image. It's a liver. Bean-shaped image, it's a kidney. A flat, long image, it's the pancreas. Okay, a flat pancake-like shape, it's the bladder. So this is how we have to judge. And any anomaly inside that can be detected with the help of a sonography. But there are two problems in sonography, air and bone. They are the biggest culprit. Now this is how an ovum pickup is done. The uterus part, the needle is injected, ovary is monitored on the sonography, the aspirate is collected in the collection tube, which you can see over here, placed at 37, very important temperature control. And this is the aspiration pump. And during this OPU, a simple propofol-based anesthesia is given. It's not a general anesthesia, but an intravenous sedation. The patient will be in a little anesthetized condition, but she will feel no pain or discomfort. These are the gadgets: ovum aspiration pump, a hot block to keep the tubes perfectly incubated. This is the culture media. These are the OCCs, the oocyte granular complex, which are aspirated. This is the trocar of the aspiration tube, which goes in, it scoops as if like a curettage effect. So these are all the gadgets which an embryologist has to be thorough with. They have to be made prepared at the time of the procedure. Now this is how it goes. The vaginal probe, along with the guide, the needle enters to the fornix, goes into the follicle, pressure is on, the follicle slowly collapses and the aspirate is collected. And this is usually when we do an abdominal sonography using a 4D. You can see the complete image of the child. You can see the child moving. You can see a child sucking the thumb. So these are advanced technologies. Imaging technology has gone phenomenally sky high. It is very good for general OBGYN also and for infertility also. Now, I target the procedures. So when I target the procedure, it has to be a good interplay between the sperm and the eggs. Now, this is the WHO definition of sperm. For clinical andrology, for male infertility, for reproductive toxicity, in epidemiology and pregnancy risk management. Now, WHO has its own standardized volumes. Now, it has gone down since years. Majority of the parameters are quite the same. But you see the normal forms, they have dropped down 50, 30, 14 and a pathetic 4. Now, this is the challenge. Because even in the most normal fertile man, the number or the percentage of the functional sperm are just 4%. Now, this was the latest WHO manual, which was released just a couple of months back, 2020. These are all the old versions. Now, this is the general view of the male anatomy. Now, when I say I want to study the seminal parameters. I will just take into consideration the volume, the pH, and then I will judge the functioning capacity of the accessory glands. Because if I see a sperm or a sample of a semen, 0.1 to 0.2 ml, transparent, completely acidic, the patient says, no, sir, I was not able to justify the collection. What he has done, he has just connected the initial part of the lubrication phase, which is the expulsion of the bulbourethral gland. Because I can show you back again, 1 second, the last slide here. Because when the initial ejaculation phase comes, excitation phase comes, the bulbourethral glands will give out the secretion because the exit for the urine and the semen is the same. So this area has to be washed clean. So the initial ejaculate consists of just the bulbourethral secretion, which washes the entire penile tract of all urine residue. Then the exit stimulus comes. Stimulation is a manifestation of the nerves put together. The contraction comes in what we call it as the orgasmic phase. So the first squirt consists of a chunk of the sperm followed by a little bit of prostatic secretion followed by the seminal vesicle secretion. So this is what exactly I have tried to tell you. Seminal vesicle quantity wise, the pH wise. So a well-documented semen analysis report makes things very easy for the andrologist to say, what is wrong with him? Is the functioning capacity of the accessories okay? Is the pH okay? There can be a block, etc., etc. Because these are the contents in a normal semen sample. Many a times a gentleman has prostatitis, continuous feeling of burning sensation in the tip of the prepuce area of the penis, feels like voiding urine, is not able to void, he voids just a few ml. Well, it could be a lower UTI infection, it can be prostatitis. Suggest to him semen examination, suggest to him urine examination. Pus cells are plenty in the urine, it's UTI. Pus cells are plenty in the semen, it's prostatitis. Seminal vesiculitis. Sometimes gentlemen come with large volumes, 7 ml, 8 ml. It can be a large abstinence period, or it can be infection of the seminal vesicles, because seminal vesicles and prostate are secretory glands. The tubules are lined by tall columnar striated epithelial secretory cells. So whenever there is an infection, the seminal vesicle gives out a large amount of secretion to wash off the infection, just like when some
Irsi sir, you are muted.
Yeah, I don't know, the host muted me. I don't know why. Anyway, now I'm okay.
Yes, sir. Yes,
Okay,
sir.
fine. Yeah. So whenever there is a large volume, there is infection of the seminal vesicles. And if you do a 24-hour sperm survival test, the 24 hours will show you bacteria teeming. That's one reason. The last one is hemospermia. Sometimes you get lightly pinkish tint semen, presence of red blood cells. Now, this is due to either prostatic carcinoma, carcinoma of the bladder, severe infection of the bladder. So whenever you spot this, please recommend the patient straight to an andrologist. Now, these are the certain tips and tricks for collection. Ideal collection room, it should mimic a perfect homely environment, because there are many apprehensions in a gentleman. There can be stress anxiety, there can be performance anxiety, there can be situational anxiety. So please don't compound the anxiety by giving him a collection room which is like a pathetic toilet. So WHO as well as ICM are in their guidelines have vividly stated that you should have a good collection room, like a homely ambience atmosphere. Don't put soap, because gentlemen lubricate. Soap is toxic. Okay. And tell them that there will be a no knock on the door. Because what happens, intermittent knocking, if you substitute your collection room for a changing room, utility room, the frame of mind gets shattered. So the delivery is not proper. So the gentleman will collect whatever he gets, and whatever he gets, we have to deal with that. But you have to tell him that if you are not able to collect the sample within the first half an hour, please don't try more, because if anybody can't collect a sample after half an hour of masturbation, the gentleman won't be able to collect a sample. And then you can't do even a biopsy of the epididymis because the musculature will go flaccid. So a good collection room, a healthy abstinence period of 3 to 5 days to allow the sperm build up the reservoir, a good container, please, large mouth plastic sterile containers with zero embryo toxicity. Because remember, this is a biological fluid. Ideally, we were using glass because glass is a media which is a super cool liquid. It has got zero reactivity with any biological fluid. You must be aware. Initially, hypodermics were of glass, saline bottles were of glass, but then the breaking, cracking, etc., made us go into the plastics. Collection method, well, some people just can't collect in the lab. They have apprehensions. Some say, nahi sir, main ghar pe hi collect karunga. Fine, give them the choice, but be careful. There can be cases of sample switchover. So we used to take up proforma writing that we, Mr. and Mrs. blah, 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 have collected the sample at a home to be utilized in the lab for this procedure, signed by the husband and the wife together. And most important is spillage. The first squirt contains the most motile fraction of the sperm, at least 40 to 45%. So if the first squirt is missed, unfortunately, the chunk of the sperm is missed. And last but not the least, added assistance as far as vibrator is concerned or electroejaculation. So what will an embryologist do? He will just check all these basal parameters and judge at a glance whether the male factor is there or not there. He will immediately report to your doctor. So half of the tension is over, half of the battle is won. And remember, one semen sample is not an ideal characteristic. You have to repeat the sample collection 3 times with 15 days gap and 4 days abstinence prior to each collection. It is not like blood, it will be present mostly at that time. It all depends upon the mental state of the gentleman when he collects and delivers the sample. That's why early morning collections or the morning collections are preferable to evening collections. Now, these are the nomenclature: normo, oligo, astheno, terato. Majority of us nowadays come under this. A mixture of oligo, astheno, and terato. Low count, low motility, and poor morphology. And last is aspermia, means a gentleman just can't collect the sperm. So to measure all the characters, we have got improvised costly gadgets like CASA, computer-assisted semen analysis, where they undergo and they measure all this. But till today, I trust the human eye much better than CASA. Then what we do with them? We have our media. We wash them in the media. We give them ideal environment. We don't compromise the pH. So we can separate them by a simple wash media, or you can separate them by the double density gradient method, and we capacitate the sperm. Now, what is capacitation? Capacitation is to make the sperm functionally viable, increase their efficiency. It increases the functional maturation of the spermatozoa, because sperm acrosome is like onion peels, one peel after the another. So in capacitation, we remove the glycoprotein layer, capacitate or activate the sperm more by the ion channel activation. And we do it by a sperm wash. Assess the sperm, mix the media, centrifuge, discard the supernatant. The pellet is again washed, discarded, layered, and the top aspirate is taken. This is taken in case of very good normospermic samples, or in suboptimal sample, there is density discontinuous gradient method. 2 medias are layered one over the other. Sperm are layered, they are spun, and depending upon the specific density, the sperm will come and settle down at the bottom, and all the detrimental things will be separated into the interfaces. So we have a technique of how to filter out the best sperm from even suboptimal samples. And then we go into the 3 techniques: intrauterine insemination, IVF, or ICSI. Now, IUI was what? I handle only one part of the gamete outside the body, that's the male sperm. The female parts are monitored inside. So till today, WHO had not considered IUI as a part of ART. But as long as it gives a patient a satisfaction of a child, it is considered as a technique. So mild male factor, cervical factor. Initially, there was intravaginal insemination. You just squirt the semen in the internal vagina part, and bingo, the procedures were there. Rates were quite less. Then came with the stimulation pattern. The lady was stimulated with exogenous hormones. So that improved the quality of the oocyte. Whereas we, on the other hand, are improving the quality of the sperm by our wash techniques. And this is how the procedure is done. The washed semen sample or aspirate is inseminated into the uterine cavity at the time of the rupture of the oocyte. Because what happens? You liberate the sperm over here, and the HCG trigger acts, egg ruptures, egg meets the sperm over here, and slowly the fertilization takes place over here, and then the procedure of embryogenesis will complete. So this is where the quality of the follicle, the health of the tube, and the health of the uterus plays a very important part. Now coming to a little difficult part, IVF, where the sperm and the egg meet on their own. There is no interference on our part. So what we do, we aspirate the eggs, we inseminate them, layer the sperm around them, and we check for the progression. Whereas in ICSI, severe male factor, intracytoplasmic sperm injection, what we do, we inject the sperm. So this is a diagrammatic, an IVF procedure, and this is the ICSI procedure. We catch a sperm individually, make it non-motile. We denude the egg, check the quality of the egg, and we transfer or inject the sperm into the egg cytoplasm. And subsequently, we monitor the progress. But here there are lots of dexterity needed, the environmental factors needed, the stress on the egg needed, and till date, we cannot monitor or we cannot say with an authenticity that this is the best sperm I have harvested and I have injected into one of the best oocytes. Whereas in IVF, each sperm will be selected by the best egg. So when you get a zygote in IVF, you are sure that the culture condition is quite similar to a utero condition. You need not worry. Now this is classical IVF, the sperm selecting the egg. This is ICSI, the sperm being injected into an egg. Now, well, of course, these are all the requirements which you need in a fantastic IVF laboratory, because you have to take care of QA/QC, you have to take care of air quality, temperature, epigenetic agents, etc., etc. It's a very difficult procedure, much more difficult than the procedure of embryology itself. Now, this is a manipulator. This side is the holding arm where you hold the oocyte, and this part maybe the injecting part where you inject the sperm. Micro means they move to a millimeter, fraction of a millimeter here and there. Imagine the needle is so thin it aspirates just one single sperm. This keeps it and then we puncture it. Now we have to be selective of the nature of the egg and the nature of the sperm. That's very, very important. Now these are the, of course, different things which are needed. We need benchtop incubators, we need stereo zooms, we need a manipulator, manual motorized, we need air quality system monitoring, we need zero embryo toxicity, disposables or gadgets. We use online filters between the incubator and the CO2 cylinder. We use cryopreservation gadgets, we use vapor shippers, cryocans. The list is endless. Because what we have to do, we have to monitor the development of embryology on a time scale. We want that a certain stage should be there at a certain hour time. There is a leeway of 1 hour here and there, but anything well beyond the time scale is pathetic. Implantation potential will be as good as zero. So whenever we do, we have to follow the time scale of development. For this, we have got advanced gadgetry like embryoscope, which will continuously record the filming of the entire events, but it comes at an astronomical cost ranging from 70 lakhs to 1 crore 20 lakhs, which is beyond the pocket capacity of many an individual IVF specialist, unless and until there is a corporate hospital or a mega setup which invests into such a machinery. Because you know what it does? It takes care of every goddamn small article. micronucleation, multiple nucleation, fragmentation, growth phase, arrest phase, development phase. Because what we got to do is post-insemination or injection, this scale has to be followed religiously. Any deviation, now suppose somebody tells me I'm seeing a 4-cell stage at 60 hours, oh, it's worth the dustbin. Howsoever excellent quality embryo this may be. So this is the jurisdiction of the embryologist to select. So this comes with the embryo grading and embryo selection. Now this is exactly what happens in your tubes. Starting point, rupture, fertilization, okay, zygote, different area, different secretion, different gaseous concentration, pyruvate lactate high, glucose low. As it progresses, pyruvate lactate low, glucose high, oxygen concentration.
बंद कर दी उधर शटल बंद हो गया खुला है
Aerobic concentration of oxygen is high. So this tells you this tells you the importance of a perfect open functional tube. So this tells you why this tube is like a glorified incubator. So what we are doing in our lab, we are mimicking all the stages in our compact control box incubator or your benchtop incubator. Now this is how you prepare your dishes: droplet culture, layer with oil, open culture. And this is the importance of media, the contents of the media. What should a media overcome? What an ideal media should do? And what a suboptimal media will result in. Pattern of culture. Different media at different steps. For follicle flushing, HIPPIS media, scanning, HIPPIS media. Then there is bicarbonate media, because media have to be incubated, which are HIPPIS based, and advanced culture media have to be equilibrated into a CO2 incubator to bring them at a proper stage. And every step of infertility treatment or ART embryology treatment mimics our human body. In the HEPA filter, high efficiency particulate air, the capacity or the filtering capacity of the main HEPA filter is 0.3 microns, because our nasal mucosa is capable of filtering particulate matter till 0.3 microns. If it is less than that, we get rhinitis. Or the infusion of carbon dioxide into a CO2 incubator. So our ideal culture condition is 37 degrees temperature, 5 or 6% carbon dioxide and ambient humidity, because this will help the progression from a zygote to a 2-cell, 4-cell, blastocyst, and last and not the least is the embryo culture. Okay, this is again we repeated, sorry. Yeah, now most important, the embryo transfer. Grade them, select them, check the endometrium, see the priming, see the development, see the proliferation. Then you give a position to the patient, check the cervix. One sec, I'll show you. Yeah. So this is the cuspospeculum which is inserted. The patient is in a lithotomy position. The embryos are graded. The uterine anatomy is graded. The proliferation is graded. And then the procedure is commenced through this embryo transfer catheters, which are simple, small plastic tubes, again of zero embryo toxicity, wherein they are transferred all the way into the uterine cavity. You see the embryo catheter coming in, the external os and the internal os. There is the mid cavity, the embryos are liberated. This is the area of maximum implantation. The uterus has proliferated. This is an eco-sensitive tube. And slowly we dispense them over there. We nestle them. The procedure is the most simple, at the same time a little difficult, but it is absolutely responsible for bringing down the results, because many a times the results are thwarted because of poor embryo transfers. A mock transfer. Now, what is a mock transfer? When a patient comes prior to you initially, you have to see whether the functionality of the whole tract is proper or not, because there can be hostile cervix, unhealthy cervix, cicatrized cervix, pinpoint os, misplaced os, severe angulation between the uterine cervix angulation. anteverted uterus, retroverted uterus. So all these things have to be noted down on paper, because at the time when the embryo transfer is going to take place, you cannot compromise with excellent embryos already loaded. And then you say, oh my gosh, there's a polyp sitting on the external os. I can't do an ET. That's disaster. That's unethical. So this is exactly how it is done. You see how the angulation is. Now this is a severe uterocervical angulation. This is quite a straight form, because what is done? The bladder on the top is a crucial factor. So prior to every transfer, the patient should be partly filled with bladder, because the bladder will strengthen, or it will straighten the passage. So the cavity of the catheter will go easily. See, this is the bolus which is kept over here. This is how the embryos are transferred. This is the external catheter. This is the internal catheter, which is loaded inside. And this is a lovely proliferated endometrium, triple layered. Now, aneuploidy, as I said, age, the crucial factor. Chromosomal abnormalities increase, the implantation decreases. Maternal age increases, aneuploidy increases. Chances of miscarriage increases as the age increases. So maternal ages are very important. That's the sad part, because in our country, people panic 2 months after marriage or 10 years after marriage. And by the time they come, it is already too late, because the internal system has gone for a toss. The endocrines have gone for a toss. They have gained weight. There are multiple problems which are cropping up. And last but not the least, when implantation has taken place, well, what are the signs? 4 signs of intrauterine pregnancy: gestational sac, yolk sac, embryo, and the cardiac activity. So when you transfer, by 14th day, you should see a beta HCG level from 90 to 120, which will increase geometrically after 48 hours. Later on, after 6 weeks or 4 to 6 weeks, you see the cardiac activity, the pulsatility of the heart. Now, this means that there is a live intrauterine fetus which you are carrying. Then there are occasional trimester investigations just to monitor the fetal health. Now, in cases of couples or ladies elderly, there are many other triple markers which are being studied to see: spina bifida, head abnormalities. So this is the work of a skillful neonatologist or a sonologist who will judge any fetal abnormality. Now, every time a high beta HCG level, supposed to the tune of 90 to 110, doesn't speak wonders. There can be false positives. There can be a blighted ovum. There can be chemical pregnancy, a molar pregnancy, or a biochemical pregnancy. And ultimately, they will all lead into miscarriage subsequently. And what we get? We have to keep the patient subsequently on luteal support. Now, luteal support, it is mostly by progesterone. Because what does it do? It prepares the endometrium for implantation. Okay, so that it will not reject the arrival of an embryo or the subsequent implantation by the fetus. So these are the steps: embryo transfer or IUI insemination, check the beta HCG levels, repeat, it will rise, post-uterine support continues, fetal or cardiac activity, pregnancy through various trimesters, and the final success or the final benchmark of success of any parameter of a life is the take-home baby weight. Now, this is a very nice figure. A lady had undergone a complete cycle of infertility, and she had collected all the vials and the ampoules and the syringes which she had utilized during her treatment. So finally, when the child was born, this is the way she decorated her. A nice, cute way. So this is a simple statement. And this is, of course, thanks to this ERT, the place where I train. Whereas we have our well-regulated, modulated courses, right from andrology to advanced techniques. It depends upon your choice of selection, when to take, how to take. And this is, of course, thanks to my company, who is up to its neck in involving itself with all the IVF related products and brochures and producers. Okay, so here I end my talk. Thank you for a patient hearing.
Yes, thank you very much, sir. Now the topic is open for discussion. The students and the faculty member from university, colleges, they can ask the question. Or if you have any doubt, you can write in
Yeah,
your
you can
chat
have,
box
sir,
also.
you can have any difficulty. You can even mail me at any time.
Yeah.
This is my WhatsApp number also. Okay,
Yes.
if you are asking for any courses or subsequently in the event of you enthusiastic enough to take embryology, because see, embryology doesn't mean just lab work. Embryology is a detailed thing. Today, there are lots of avenues. There is genetics and infertility. There is what we call it as a embryo selection, the biopsies. Okay, stem cell culture, pre-implantation genetic diagnosis. There are lots of things. I think one or two topics you will be covering in our the system also. I think we have some 2, 3. I think this nanotechnology is there, then sequencing is there, detection of techniques are there. I think they are also a part and parcel of it. So don't think that embryology is only related to the laboratory sperm and eggs. But yes, you need to have some basic knowledge of the functioning. You need to have some sort of a limited hands-on, or at least you should be able to distinguish between a grade 1 embryo and a grade 3 embryo, a day 2 embryo or a day 5 embryo. So unless and until those initial steps are not treaded upon carefully, later on, the field of research will be a little difficult for you. So it is that, well, take care when you take the first step.
Yes. Any questions or? Okay, sir.
Madam?
Yes. Yes.
Madam, I have one question.
Yes, Nagesh, ask. You can ask.
Thank you, sir, for this very informative session. Just now we came to know about multiple complex tests. It was very informative. My question is that prior to marriage, which primary and simple tests help to know if there are any reproductive disorders and about good reproductive health that needs to be done to avoid further complications in both male and female counterparts?
So I think it's a very dicey question you have asked me. So it's like a prerequisite before a marriage, something of that sort. See, usually what happens is if any problem in a lady or a young or a lady, okay, because she will come to know of this initially only when she has disturbances in her menstrual cycle. Her periods are long, her periods are short, her postluteal phase is short, her bleed pattern is heavy, scanty, you know.
Yes.
And as far as the male is concerned, maybe his developmental pattern or his appearance like an excessive of estrogen in the body, or we cannot have a compulsory semen analysis for every bachelor boy prior to a marriage also, just to use the function. Because as I told you, there are a number of, suppose if I just catch anybody and say, chalo bhaiya, tumhara shadi ke pehle ye test karna hai, to obviously he'll go into a trauma. So his delivery will be pathetic. So there will be a situational anxiety. So the sperm count will definitely come less. This is exactly what happens today in an IUI. The actual clinical pregnancy rates are 5 to 12%. But in non-indicative cases, they shoot up to 25%. Because young couples who come, now they are stressed with the career imaging, career developing imaging. So there's space of the childbearing age is after 1 year, then suddenly overcome by the pressure and the tension from the parents and the friends, they suddenly want to become pregnant overnight. Now that doesn't happen. So ultimately they rush to a clinician. We explain them that you are perfectly normal. Just 2 or 3 months of more trying time will help you. But they say nothing doing. You treat us or we are going to another person. So we tell them, okay, we are going to treat you. The very fact that we tell them, you know, that block is removed. So the stress is removed. So they end up in pregnancies. As a matter of fact, there is a publication, or there are publications which state that once a person has a few failed cycles and a person has now given up the hopes of childbearing, there is a 40% chance of those couples conceiving spontaneously after 6 to 7 months on their own. The reason why? The stress factor is completely eliminated. They had erased that mental block of infertility and they said, forget it, we are going to enjoy our life. So this is the real bottom line. So prior to it, it is very difficult for us to judge whether what will be the blah blah condition. Of course, some are visible conditions, some are visible changes, and those visible changes will be more in the lady because she bleeds, she menstruates every cycle. And accordingly, there will be body changes, like a PCOS girl will be having a pear-shaped figure. Or sorry to say, a boy who has his androgenicity reduced also will be having a little feminine figures with a girlish voice, scanty hair development. So we can also judge by that. So that is what, if any of a problem, initial investigation by an andrologist or an endocrinologist will help you solve the case.
Yes, sir.
Thank you, sir.
Thank you very much, Dr. Kirsi Avri, a renowned endocrinologist, for giving a very informative and interesting talk on infertility and enigma, causes and cures, advances in assisted reproductive technology. Yes, sir. Still in 21st century, our society considered infertility as a punishment, sir. And so it is very essential to know the science behind this infertility, and not for zoologists, but for everyone, sir. Sir, very nicely with beautiful pictures, you have explained each and every aspect of male infertility, female infertility, reproductive systems, spermatogenesis, oogenesis, and histological pictures are very, very nice, sir. Sir, again, thank you, sir. Very nicely, very systematic manner, with beautiful pictures, you have explained each and every aspect, each and everything, sir. Sir, on behalf of Department of Zoology, Shivaji University, Kolhapur, I am very much thankful for giving an opening lecture in this Zoology in 21st Century lecture series. Thank you. Thank you very much, sir. Thank you.
Thank you, ma'am. Of course, this is an incorporation of so many topics. What I was able to do, I just condensed everything into it. Otherwise, each topic can run for hours together. Still, I have tried my level best to explain all of you in a condensed form. Anyway, thank you very much.
Okay.
Thank you for involving me. It's a pleasure being with you, and I'll try to be with you as much as possible on the oncoming days.
Yes, sir. Thank you.
Fine.
Thank you.
And let's keep in touch. Out of sight should not be out of mind.
Yes,
Okay?
sir. Thank you.
Fine. Okay. Thank you very much.
Thank you.
You can proceed with your next sessions.
Okay,
Yes,
thank
sir.
you.
Thank you, sir. Thank you so
Welcome.
much.
Most welcome.
Thank you. Yes.
Madam, Dr. Sharda Sawant from ACTRACT had joined this inauguration and keynote lecture also. So, Madam, welcome to this lecture series. Yeah. Hello. Now, we'll take a break here, and next lecture will begin at 3 p.m. So I request you all kindly join the lecture series for next lecture at 3 p.m. Dr.
Okay.
Suhas Vaingankar will be the speaker for that lecture.
Okay. Thank you, sir.
Thank you.